My name is Alan Goodrich, and I'm a neurologist, and we're pleased to have a standardized patient, Jeff Sims, here today, and thank you, Jeff, for doing this very much.
No problem.
What we're going to do for this demonstration is the cranial nerve exam, and before we started this video, I washed my hands, which must be done before each patient encounter. So we're going to run, the cranial nerve exam is organized numerically. So for different components of the cranial nerve exam, we'll be doing motor or sensory components or reflex components. And so the standard practice is to do it in a numerical fashion. So we'll start off with the first cranial nerve, the olfactory nerve. And I suppose the truth is we don't routinely check that. We can think about it and ask the person, do you have a normal sense of smell? And that may be all we need to do. If we want to take it a step further, for example, in somebody who's had a head injury, perhaps with a basal skull fracture, somebody has a neurodegenerative disease like Parkinson's, sense of smell may be affected. And we could test it a little bit further, and I'm going to ask you to smell this little, I'll just show, I should scratch that first and take a little sniff. I'll give you a choice of lilac, chili, coconut, or whiskey. What did you smell?
Lilac.
And that is correct. We could check both nostrils, and we have other smells we could test if we had to go further with that. Normally, it's a simple question. Now, for the second cranial nerve, the optic nerve, we could start off with just visual acuity. And I'll ask Jeff to cover one eye and to hold that approximately 14 inches away from you, a little over a foot. And just read the smallest line that you can read there, Jeff.
937826.
Excellent, thank you. So Jeff has excellent visual acuity, and we could check that with both eyes if in the real life situation. The next thing we'll do the fundoscopic exam. I'm just going to make a few brief points. I'm not going to do a comprehensive fundoscopic exam, but I'm going to make a couple of brief points on the fundoscopic exam, because a lot of people have trouble getting going with this. A couple of practical points. So if I keep, as the examiner, keep my eye parallel to the person I'm examining, I'm more or less on the same horizontal plane. And from this distance, I'm about I can see the red reflex, and I'm, let's say, roughly 45 degrees off the center. Now, I know the light is going to land on the medial aspect of the retina, so I just stay the straight line, following the medial part of the retina, and at a certain point, which happens to be right now, I can see a red blood vessel on the retina. So I see that blood vessel right now, and I just move my head medially, so the light is going more laterally, and at this point, I see the optic disc quite clearly. So a few simple rules. Just approach the patient 45-degree angle. You'll see the light reflex. Then you'll see a blood vessel. Follow the blood vessel by moving your head medially. The light will go laterally, and you'll always come to the disc. Once you're able to do that, you can spend time observing the disc, and then you can follow the vessels outward at the various positions to explore the vessels and then the retina more thoroughly. Now, the next thing what we'll do is visual fields, and appreciate that there's a number of different ways to test the visual fields. I'm going to show you a few methods that I find particularly helpful, but there are nuances of the way to do that that will also be equally reasonable or equally correct. Now, we'll start off with just basic screening. And so what I'll do is I'm going to have my back to you right now, but I'm going to ask Jeff to look straight at my face, and I'm going to have my arms out very much on the periphery. And I'm just going to ask Jeff if he can, which side is moving?
Side.
And now?
Oh.
So he's got both eyes open, and I'm just checking the temporal visual field. So when I moved my hand out here, I was checking his left temporal visual field. At that point, when I did it that way with both eyes opened, my arm is out far enough that the right eye is not seeing over in the left temporal visual field. That's a very useful screening test that we often do. For example, in the emergency department with somebody who may have had a stroke. So that's a kind of a quick, easy screening test. And we can also stimulate bilaterally. Which hand is moving? One or two sides?
Both.
And now, one or two sides?
One.
Now?
Both.
Okay. Great screening test to start off with. Now, to do this a bit more, say, thoroughly, we can check each eye individually. And I'll show you another technique where I'll ask Jeff to, say, cover your left eye. And now I'm going to have my back to you again, but I'll ask Jeff to look into my eye. And I'm going to have him count my fingers, 1 or 2 fingers. So how many fingers do you see now?
1.
In total?
Oh, 2, sorry.
Okay, and now?
4.
And now?
3.
Now, and then we can do that with both eyes. That's a very useful way, an effective way to check the visual fields. A couple of details to keep in mind when I do this. I'm near the midline. Close one eye again, please. I'm imagining, for example, a cross with the intersection of the cross in the middle of his pupil. And then I'm in the 4 quadrants above or below that. I'm near the midline, though. It's very difficult to count fingers if we're way off in the periphery. So I'm near the midline, and I'm only using 1 or 2 fingers. And that's really an excellent way to do visual field testing. Okay, Jeff, I'm just going to test your visual field. So let's think now if somebody may have had a stroke, for example, with a left homonymous hemianopia. They've lost their left hemifield. I'll demonstrate what sort of a response we might get. So let's have you cover your right eye there first. Now, when I'm moving my finger out in Jeff's left hemifield, he may not see that. He'll say, no, no movement, no movement, no movement. And when I approach the midline, he will see that when I get it basically to his right visual field. Now, if I have you cover your left eye, look straight at my eye. Now, Jeff's visual field, because he's got the nose in the way, has got and there's a narrower field than it is with his left eye, because he doesn't have the nose obstructing things. So we can try to identify, you can try to identify the periphery of your own visual field. So I'm going to close my right eye, and I bring my finger down. I can see that's about the point where I can see my finger. And you can actually see Jeff was nodding there. He could see it at the same point. If Jeff had a left hemifield defect, I can see my finger now, and he couldn't. If it was a left visual, no, 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 no. And then when he reached the midline, then he would start to see the image again. And so that's another useful technique. So I think that's sort of the main elements of the second cranial nerve exam. One other thing I should add, though, is what I've been demonstrating with the visual fields are the peripheral visual fields. You can also have a visual disturbance, of course, if you have a problem with the optic nerve. And that could happen in somebody with optic neuritis, perhaps with MS, or an ischemic optic neuropathy. So there's a couple of things we can do. We could first of all just start off by asking Jeff, do you see my face clearly? Do you see my face clearly? And if there was an optic nerve problem, Jeff would be able to say that he doesn't see my face clearly or things are dimmer. You could take a red object, for example, and does that appear to be a normal bright red object? Does that seem to be the same? If there was an optic nerve problem, this bright red object would appear darker, and that would be another clue. Of course, visual acuity would also be impaired if there's a central visual problem, such as an ischemic optic neuropathy. The third, fourth, and sixth cranial nerves, which we will examine collectively, along with the autonomic innervation to the pupil. So let's just start off with the eye movements. So I'll ask Jeff to follow my finger. Turn your eyes to the left, up and down. We go to the cardinal positions of gaze, up, laterally, and down. And what you should do as an examiner is keep in mind what you're testing. So let's just take it simple. Let's have Jeff look to the left. With the left eye, we're checking the left lateral rectus, which is innervated by the sixth cranial nerve. And with his right eye, which is moving medially, we're checking the right medial rectus, which is innervated by the third cranial nerve. Now, when we have the person look up, all right, the predominant action to look up when the eye is abducted is the superior rectus with the left eye and the inferior oblique with the right eye. And when we're looking down, we're testing here predominantly with the eye abducted. When he's looking down, we're checking the inferior rectus with the left eye and the superior rectus with the right eye. So you need to keep that basic anatomy in mind when you're doing your eye movement testing. Now, of course, when we're testing the eye movements, we're not just checking the raw function of the muscle and the nerve, but we're watching the movement as well. So we asked Jeff to follow my finger. As I'm moving my finger, he's moving his eyes sort of very closely following my finger, and his eyes are moving very smoothly. He's got normal, smooth pursuit. Now, if I ask Jeff to look quickly to the left and now to the right, those are rapid saccadic eye movements. Now, if somebody has loss of smoothness of pursuit, their eye movements will become saccadic. I'll just demonstrate that. So, Jeff, I'm going to ask you to turn your eyes to the right, and now move them as slowly as you can to the left. And what you see is a series of jerky movements, because without the target, without the visual target, it's impossible to do smooth pursuit. And what Jeff demonstrated were saccades. They were normal saccades, but if you saw that type of movement when he should be pursuing smoothly, that would be loss of smooth pursuit, and it might be an indicator, for example, of cerebellar disease. Now, the other thing is sometimes we look for is nystagmus. And in a variety of brainstem, cerebellar disorders, we can see that. Of course, we can see nystagmus in peripheral vestibular disturbances as well. I'm going to show you normal nystagmus right now, what I call optokinetic nystagmus, and we'll just take a striped object like this tie, and I'll ask Jeff to follow the tie, and you may be able to see as we're doing this demonstration, just watch the stripes go by. He has jerky eye movements. He's actually, as he's trying to follow the stripes, for example, in that case towards the right, and then there was a rapid corrective movement, a fast nystagmus movement towards the left side. So that's normal optokinetic nystagmus, but in a variety of disorders of the vestibular system, you will see those occurring spontaneously. Now let's look at the pupils. And of course, normal pupils are the same size or almost the same size. Some minor degrees of anisocoria is normal. But if we shine the light in the right eye, we see a nice, good, direct pupil response. And then while I'm shining the light in the right eye, I'm also can look at the left eye to see that there's a normal consensual response. In other words, a corresponding constriction of the contralateral pupil as well. And of course, I can do that on both sides. So that's a normal light response. Now, also, the other thing to keep in mind is the near response. The near response is something that we use when people are trying to look, say, to read a book that is close in front of them. And so if I ask Jeff to look at this pin way out here, keep looking at the pin, and keep looking, and keep looking. And as he's doing that, I'm seeing that the pupils are constricting again. That's part of a normal near response. The near response has three elements. One is the pupil constriction, which we just demonstrated, but also, of course, the eyes are converging to look closer. And there's another element that you're not seeing, which is part of this response. The lens are accommodating. They're changing their shape so they can be more powerful to bend the light for near vision. So those are three elements of the near response. We're seeing the two elements. We're seeing the pupil constriction and the eye convergence. So that's the third, fourth, and the sixth cranial nerves. Now for the fifth cranial nerve, we'll focus on the sensory elements. So we've got the ophthalmic, maxillary, and mandibular divisions of the trigeminal nerve, V1, V2, and V3. And so on the sensory side of the trigeminal nerve, we can check sensation, for example, with a safety pin. I think a safety pin is a reasonable, it's not too sharp like a hypodermic needle. It's not too blunt like the back of a stick, for example. But I'll just ask Jeff, do you feel a bit of a pointy feeling there?
Yep.
And is that similar or different there?
Similar.
And I could check the middle and the lower portions of the face, and I should under normal circumstances. I can also just check soft touch, and I can just use my fingers. That's fine. Does that feel soft, normal, similar, or is there any differences from side to side?
Similar.
And or I could use a soft object. Again, do you feel a softness, similar or different on the two sides? Now, there's some few other things you can do that I suppose are slightly more objective. We could do a corneal response. I'd say normally we're not doing the corneal response at the bedside unless there was sort of perhaps very clear, compelling evidence that you were assessing for a trigeminal neuropathy. We more commonly would do this in the emergency department or in the intensive care unit when somebody has altered levels of consciousness, where this can be also helpful. But I will do it for demonstration purposes. I've taken a tissue, I've made it into a sort of a neat point, and I'm just going to ask Jeff to look up and away for a moment. I'm touching the cornea. It's a brisk response. It's slightly unpleasant. I apologize for that. But I will show, I'm not going to touch your cornea anymore, but just look up in a way. But I will touch the sclera, and you'll appreciate virtually nothing happens. You probably could feel that, but it's just a crude sensation and does not generate the same brisk response as when you touch the cornea. So that's the corneal response. And then there's the nasal tickle. And we do that, and people invariably will have a little response like that, and they'll get a bit of a smile. And there's probably a combination of V1 and V2. There are nasociliary fibers coming down through the nose, and that's the first cranial nerve, and some going just on the inside of the nose from the maxillary nerve. So it's probably a combination of both of those branches that we're testing. We could also use test temperature sensation, and that's useful. Sometimes people have brainstem strokes, and they'll lose temperature and sensation along with pin on one side of the face. So do you feel the cold object there? Does that feel similar or different?
Similar.
Similar, and again, we could check all three divisions. So that's the sensory side of the trigeminal nerve. The motor side is really focused on the mandibular division of the trigeminal nerve and movements of the jaw. We could do some simple observation. We could ask you to bite your teeth together, and we could look at the masseter muscles and the temporalis muscles. I know it's traditionally talked about feeling these muscles. I'm not sure feeling them is particularly helpful. I think you're observing to see how these muscles scalloped out. I don't find palpation of the muscles particularly helpful. We need to think about those muscles and observe them. We could check for jaw opening. Open your mouth widely. All right, and that's there we're testing the lateral pterygoid muscles, among others. And then close your mouth firmly. You could try to open them. That's testing masseter and medial pterygoid and your temporalis muscles. We very, very rarely would see a unilateral lesion. If there was a unilateral lesion, it's going to have you open your mouth, the jaw would deviate. For example, if there's a unilateral lesion on the right side of the muscles of mastication, then the side that's working on the left side will pull the jaw closer to the skull. So the muscles that are working pulls the jaw closer to the skull, and the jaw would deviate to the affected side. So really, I think all you need to do in that regard is open the mouth and look for a jaw deviation, keeping in mind that temporal mandibular joint dysfunction can do the same thing. What we do more commonly is see patients with bilateral problems, for example, with the upper motor neuron, such as maybe bilateral strokes. And those people can have a lot of trouble just opening the jaw. There might be a lot of jaw weakness. We can also see that in neuromuscular problems such as myasthenia gravis, muscular dystrophies. That sort of thing can cause jaw weakness. So that's just some of the things to think about with the trigeminal nerve problems. Now let's go on then to the seventh cranial nerve, the facial nerve. And we can look at facial strength in the first instance, all right? So we can first of all just stand back and have a look at Jeff's face, and we don't see any obvious weakness of the face. We can ask him to show us his teeth, and we can see nice nasolabial folds emerging. We can ask you to draw your mouth downwards, and we can see the platysma muscle prominent. We can ask you to close your eyes very firmly, as tight as you possibly can. And when a person closes their eyes very tightly like this, you can open them now, the eyelids are actually buried. And that's what you're really looking for. Raise your eyebrows up. And so that's good, thank you. And so we've had a good sampling of the facial muscles. We can see they're all normal. Now, some people get mixed up with the variation of the patterns of facial weakness with upper and lower motor neuron problems. So the way I would think of it, to exaggerate the point, if you have a seventh cranial nerve palsy, for example, the nerve was cut, perhaps in an accident, so you can appreciate if that seventh cranial nerve was, well, that seventh cranial nerve supplies the whole side of that face. So if we have a complete seventh nerve palsy, we will get weakness of the entirety of the face. Whereas if there's a problem with the upper motor neuron, in other words, the central nervous system, the corticobulbar tracts, there's a lot of bilateral innervation in that situation, and typically the forehead is bilateral innervation by the upper motor neuron. So with most strokes, for example, if there's a stroke involving the right hemisphere, we'll get weakness in the left lower part of the face. And so the reason we get the lower part of the face involved and not the upper is because there's bilateral innervation that protects the upper part of the face. Now, so that's a bit about the motor side of things. The seventh cranial nerve also does a special sensory innervation to the tongue, so there's sensation for the anterior 2/3 of the tongue. I think testing this taste is not very practical. I think it's awkward and not something people do routinely, and I don't recommend that. We should ask, do you have normal taste? Okay. Somebody had a facial palsy, they may have changed their taste, they might be able to report that to you. The seventh cranial nerve also supplies a muscle to stapedius muscle. So if somebody has a facial nerve palsy, the function of the stapedius muscle is to dampen down high-pitched or rather loud noises to make them less loud and less annoying. And so do you have any sensitivity to loud noises? Okay. And then there's a minor sensory component of the seventh cranial nerve, the tympanic membrane, a little bit of the external auditory meatus, which we normally would not be testing. So I think those are the main points on the seventh cranial nerve. Now we'll go to the eighth cranial nerve, the vestibulocochlear nerve. I suppose most of our direct testing is really with the cochlear nerve. Keep in mind if there's vestibular dysfunction, we may see nystagmus. The person may be complaining of vertigo, for example. Thinking of the cochlear aspect of the vestibulocochlear nerve, or the eighth cranial nerve, we first of all would like to make sure that the ear canals are clear. Do you have any trouble with your hearing? Okay. So if somebody has trouble with their hearing, we can take it a step further. So one of the things we could do is have you put your hand over one ear. So I'm going to check Jeff's hearing. I'm going to whisper something from him several feet away and ask if you can repeat what I've just said.
3, 2.
Perfect. So that's good hearing. In the setting of reduced hearing, there are other things we can do, such as the Weber and Rene test. And the purpose of those tests is to help understand the nature of the hearing loss. Is it more of a problem with the conduction system or with the nerve itself? So what I could do, for example, is take a tuning fork. We could use different frequencies. I have a 256 tuning fork here right now. And I'll do the first test. Is called the Weber's test, W-E-B-E-R. And tell me where you hear that sound.
In the middle.
In the middle. So that's a normal response. If Jeff said I heard it in both ears, that would be fine as well. Just to remind you, the Weber test, W is spelled W-E-B-E-R, so we can think of it as the central letter is B. We're putting the tuning fork on the bone between the two E's, between the two ears. And that often helps people remember that. If there's a problem with the conduction system, we'll just see what happens with Jeff. I'm going to create a conduction hearing defect by blocking his right ear. So tell me where you hear the sound right now.
My right ear.
So I blocked off the external ear canal with my thumb, and sound gravitated towards that side. Now you can appreciate if there's a problem with the nerve, and to exaggerate the point, imagine if the nerve was cut, you wouldn't hear anything on the right ear, he would hear things on the left. Now the other thing we want to demonstrate is whether air conduction, AIR conduction, is better than bone conduction, which is normal. So what I can do is I have I'm vibrating the tuning fork, and do you hear the ringing in your ears? It'll fade away quite slowly. Tell me when it's gone. It's gone. And now, do you hear it? You do hear it. So what we've demonstrated is that air conduction is better than bone conduction. If the situation was the reverse, it could indicate that, so an air conduction will be better than bone conduction normally, or if there's a problem with the nerve. But if there's a problem with the conduction system, then the situation will be reversed, and transmission through the bone will be better than through the air, the AIR. So that's the eighth cranial nerve. Keep in mind, if there's a vestibular dysfunction, you may see very prominent nystagmus. In a peripheral vestibular disturbance, a nystagmus classically are unilateral. The fast component is always beating in one direction. Okay, so we're now going to look at the 9th and 10th cranial nerves, the glossopharyngeal and the vagus nerve, and they're examined really as if they were a single nerve. There's a lot of overlap of the motor function and the sensory functions and autonomic functions. And so functionally, we really treat them as one large nerve. Just a few general comments. The vagus nerve has much more skeletal motor function for the pharynx and the larynx. The glossopharyngeal nerve actually just innervates one skeletal muscle, the stylopharyngeus muscle, which elevates the pharynx and the larynx. Both have autonomic function. Of course, the vagus nerve autonomic, parasympathetic function to the organs, the viscera, and then the glossopharyngeal nerve for the parotid gland. They both have sensory function and taste function for the posterior pharynx and epiglottis region. But collectively, we'll check them both together. And I suppose really what we're really focusing in on with the 9th, 10th nerve complex is the pharynx. So we can just listen to the voice. Hear Jeff speak through the assessment. But I'll just ask him to do a couple of things that involve posterior pharyngeal muscles. So can you say cuckoo clock?
Cuckoo clock.
So that's normal. And if there's a problem with pharyngeal muscles or laryngeal muscles, there might be a hoarse quality or a nasal quality, depending on where the lesion is. So we can just listen to the person. The next thing that we can do is just look at the back of the throat and open your mouth widely, please. And if you could have somebody hold a light, that would be helpful. He's got a nice, widely opened, it's quite easy to see the posterior pharyngeal and the soft palate. And open up widely and say, ah.
Ah.
And I can do a gag reflex, so I'll just ask Jeff to open his mouth. I can push the tongue down, and I'll just gently touch one side of the palate and the other side of the palate. Jeff's pretty good. He had, I would say, pretty normal or average response. Some people are super sensitive and will have a very vigorous gag response, which may make it difficult. I think probably in most cases, you'll be fine if you just have the person say, ah, and you're looking for symmetrical elevation of the soft palate. Keep in mind, if there's a lesion, such as a stroke involving the lateral part of the medulla, that's affecting, for example, the nucleus ambiguus, the palate will not be able to elevate on the affected side, and so the palate will elevate asymmetrically towards the side that's fully intact, and so it'll be pulled away from the side of the lesion. So I think that's your main testing of the 9th, 10th complex. Keep in mind that those nerves have sensory function that we normally don't test, except for checking the sensation of the posterior pharyngeal wall. So next we will look at the 11th cranial nerve, the spinal accessory nerve. And of course, that's not a cranial nerve. It's a high cervical nerve that happens to pass through within the cranial vault for a brief. It comes up through the foramen magnum and then exits through the jugular foramen. So it's given the label of a cranial nerve, but really it's a high cervical nerve which innervates the sternocleidomastoid muscle and the trapezius muscle. So for the sternocleidomastoid muscle, we can just ask Jeff to turn his head to the right, please, towards me. Okay, and we can see the sternocleidomastoid muscle arising from the mastoid process with insertions along the clavicle and the sternum. Push very firmly against my hand. We can see the muscle, we can feel the muscle, and keep in mind that the left sternocleidomastoid muscle is turning the head to the right and so on. Isolated lesions of one side of that nerve are pretty rare. What you're more likely to see is with bilateral weakness, with a variety of neuromuscular problems. ALS, muscular dystrophies, myasthenia gravis can cause weakness of the neck flexors. And so I'd say in general, you're going to find a higher yield with testing it bilaterally, the sternocleidomastoid bilaterally. So I'm going to ask Jeff just to bring your head forward and push it forward. Now we know that there's good bilateral symmetrical strength. And as I said, you'll find weakness in quite a variety of neuromuscular disorders. Now, for the trapezius muscle, sort of the knee-jerk reaction, I suppose, is to put your hands on the shoulder, lift your shoulders up, and to feel the power. I personally find that kind of awkward. I find it hard to judge, especially if there's mild degrees of weakness. And I really think for most purposes, when there's a unilateral weakness of the trapezius muscle, the simplest thing is just to observe. And this might be affected in a stroke for the trapezius is commonly affected and say with the hemiplegia as well, whereas the sternocleidomastoid typically is not. So we'll ask the person to lift their shoulders up briskly. Just you can keep your arms down, just lift it down and do that again. And we can see them, both shoulders elevating briskly and symmetrically. And I think that's in most cases sufficient for examination of the trapezius muscle. Of course, you can look at the muscle as well, and you can see the muscle bulk. Lift it up again, please, there. And we can feel the muscle, and so you can do direct observation as well. So the final cranial nerve then is the hypoglossal nerve, the examination of the tongue, and almost all of the tongue muscles are innervated by the 12th cranial nerve. So what we'll do is we'll just ask Jeff to put his tongue out, and the genioglossus muscle pushes the tongue out. In this case, it's pushing it out symmetrically, is what we would expect. Now, that's good, thank you. Sort of a popular way that's in the books is pushing the tongue against the cheek to judge strength. And my own opinion, that's of no help at all. I've not found it useful. Push your tongue against your cheek, please, to try to make a judgment of the strength. And I really haven't found that helpful at all. If there's a unilateral lesion, the tongue will deviate. The tongue will be pushed towards the affected side. So put your tongue out, please. So if there's weakness, for example, on the left side of the tongue, the right side of the tongue, which is working, will push the tongue towards the left. So the tongue, as a pushing muscle, push it towards the bad side, if there's a unilateral lesion. If there's a bilateral lesion, perhaps bilateral strokes, for example, or ALS, which might have bilateral involvement of the tongue, put your tongue out and move your tongue quickly from side to side. Far over and back and forth quickly, faster. And we can see a nice, smooth, rapid action. If there's bilateral involvement of the tongue, you'll lose that smooth, rapid action. And of course, the other thing you should do with the tongue is observe, just open your mouth widely, perhaps with the tongue in the mouth, and we can use the light to have a careful observation of the tongue to look for the presence of wasting or fasciculations. Now, a normal tongue will have some slow undulating movements. And, so you see some slight movement of the tongue and sort of larger amplitude, lower frequency movements. Fasciculations are small amplitude, high frequency movements of the tongue, sort of a quivering type of appearance. And make sure, so be careful not to overcall the presence of fasciculations when you see those slow undulating movements of the tongue. And I think that's it for the cranial nerves. So we'll call it a close there. And thank you very much for Jeff.